Good morning, everybody. I want to thank the organizers for having me here to speak on behalf of the 257 million patients living with hepatitis B, which, as a reminder, is more than triple that of Hep C and 10 times that of HIV. I'm an internist who has been caring for hepatitis B patients as part of my primary care practice for more than 10 years. First in New York City at the Charles B. Wang Community Health Center, where we had 7,000 Hep B patients, and now in New Jersey, where I am seeing mostly Asian, but also African and Caribbean patients. I'm also living with hepatitis B. I'm one of those Hep B E antigen negative patients with pre-core mutation whose viral load and ALT don't meet the guidelines for therapy, which is fine by me if my risk is truly low. But I do wonder if there truly is no inflammation, especially when I hear all these great immunology talks. I've done a lot of work in the hepatitis B field. I've trained primary care doctors to treat and care for Hep B, started programs, received many grants, including from CDC for screening and linkage to care initiatives, and I've just said I believe that the most important role in my career thus far is actually to speak on behalf of people living with hepatitis B. It has taken me years to overcome that self-stigmatization and fear that comes with having a chronic infection, and to speak openly about having hepatitis B myself. Even as a physician, it is much easier to talk about hepatitis elimination and the latest studies than to talk about what it's like living with the infection. But I have to. My patients would never talk about what it's like to have hepatitis B. But I hear their stories, and through the Hep B Foundation and the World Hepatitis Alliance, I hear stories of patients worldwide. I hear the distress, the loss of hope, the frantic search to understand this complicated disease and its lab results, the confusion of whether they need treatments, the difficulty of accessing care and medications, the struggle with compliance, the fatigue of taking medication for years, the rejection they face from their dating partners, spouses, having to sit at different tables for meals, and the tragic stories of depression and suicide. So do patients think that we need new therapies, that what we have currently is not good enough? I'm going to say unabashedly, hell yes. We need finite therapies. Right now, the endpoints are vague, and lifelong therapy is a huge burden and not realistic for many. In the US, I've had patients paying up to $300 for copays, even for generic tenofovir and entecavir. Hep B antivirals often fall into high-tier formularies, need insurance pre-authorization, and they can only get a 30-day supply with refills only allowed within a few days of running out of medication. How can this not be a barrier for compliance and eventually resistance? And globally, many patients can barely get Hep B DNA tests or see a specialist, much less access lifelong therapy. If we're going to eliminate Hep B by 2030, we need to tailor our trials, therapies, and our guidelines to reach the greatest burden of patients who are in Asia and Africa. What else do patients desperately want? And you can see this from the messages that are taken from the Hep B listserv that I'm on, and I've gotten permission from patients to share this with you. They want a cure. They want a loss of surface antigen because this is the scarlet letter. They could care less about cccDNA at this point. It's the positive surface antigen that alerts schools and jobs about the infection. The Hep B Foundation gets one call at least once a week from students, healthcare workers, or military personnel who are facing outright discrimination and being kicked out of school or fired. We need to keep our terminology simple and easy to understand. If we complicate things and qualify a cure as functional and not just simply a cure, we're in danger of inviting continued discrimination. Will the primary care doctor and administrators filling out and reviewing forms understand what functional cure means? If we have tiers and they think that sterilizing cure is a kind of gold standard, they may believe a patient is still infectious and not clear them. I have to be honest, I heard the term parafunctional cure yesterday. I almost choked on my water. It is a critical time to involve patients. I am grateful for the chance to speak and that this meeting is being live streamed. I sent the link to the patient listserv that I'm on, and I know that there are patients around the world listening to this now. But I was disappointed that patients are not listed amongst the important stakeholders for this meeting or on the list of who should attend. You may not realize it, but patients are your greatest asset. Patient-centric clinical trials are when patients are part of the study design, and outcomes are designed to be relevant and meaningful to patients. In the case of Hep B, stigma survey could be a measure. A recent Economist report concluded that patient-centric studies took less time to recruit patients. On average, they could recruit 100 patients in 4 months versus 6 to 11 months, and drugs developed with patient-centric designs were 20% more likely to be launched than those that were not. And when patients are activated, we can speak up to policymakers and funders, raise media attention, and help make Hep B a research priority. We can help find the missing millions because they are our community, and we can get them to studies and to care. So please, include us in your discussions so we can get to Hep B cure together. On behalf of those living with Hep B, I want to say nothing about us without us. Thank you.